Good evening, everyone. My name is Olivia Yale. I am with the County of Gray's Communications Department. With me tonight, I have Jennifer Cornell, the Director of Long-Term Care, and Dana Leach, who is our specialist with the County of Gray. She is the clinical specialist for long-term care. I just wanted to mention that tonight we have a disclaimer that I'll throw up on the screen. Let's see. All right, so for today, Wednesday, May 25th, 2022, this video discusses matters related to residents of long-term care homes operated by the County of Gray. Please feel free to share this video with others in the Gray County community. If you have any family members in a long-term care home not operated by Gray County, please contact that home if you have questions or concerns about their care. So to continue, just a reminder that for tonight, it'll be from 7 p.m. until 8 p.m. for this long-term care family call for Gray County. We will be answering questions, and all questions can be funneled through the Q&A feature on Zoom. So if you have any questions, please feel free to use that feature located on the bottom of your screen if you have a laptop or a desktop. If you do use a cell phone to watch tonight's call, the feature can be found at the top of your screen. So you can put in a question in the Q&A if you wish. So now I will be handing it over to Jennifer for the rest of the evening, and afterwards we will be looking at the Q&A questions. So the floor is yours, Jen.
Great, thanks so much, Olivia. Nice to see everyone. I'm just going to pull my notes over here. So thanks for joining us. Since we last met virtually on March 15th, we've seen all three homes supporting the de-escalation of a variety of pandemic strategies while still balancing the risk of infection and outbreaks. Provincially, there are 147 long-term care homes in outbreak, and locally, there are 5 long-term care homes and 3 retirement home or congregate settings in either a COVID outbreak or other respiratory illness. While we're making our way to recovery, we're not quite out of the woods yet. In this update, I will provide an update on the COVID outbreak at Lee Manor, touch on surveillance testing and masking planning, and an update to our visiting policy to safely support unvaccinated visitors. And I'm also going to provide a short overview of the Fixing Long-Term Care Home Act and regulations. So jumping right in, currently Lee Manor is managing an outbreak of COVID-19 on the home area that is 3 North. It was declared on May 14th. This is the first COVID outbreak with residents testing positive on that home area of 3 North. The initial resident was identified as part of our surveillance protocols that are required when someone returns from an absence. The resident was immediately put on isolation protocols, as well as anyone identified as a potential high-risk contact as per public health. To date, after 4 rounds of resident testing, so residents and staff have persevered throughout that protocol of testing, a total of 15 residents have been identified as positive for COVID. Each resident has been closely monitored, and for those who are eligible and consented, Paxlovid was ordered by their physician, and that's the medication that is now available to support a group of individuals that are eligible for that medication. We also have 9 staff who have tested positive. Public Health has reviewed these cases as well, and have not identified any lapses of IPAC protocols within our staff or our outbreak management. We also found out today that the variant has been identified as Omicron B.1.1.529, And what does that mean? Excellent question. So there is substantial scientific and experiential evidence that Omicron is more transmissible, has a higher growth rate, a higher attack rate, and a higher basic reproduction number than other lineages. As well with this variant, the period of communicability for Omicron peaks at around 3 to 6 days post-symptom onset. So for us to see some negative tests during the first or second round of testing and then see them become positive in the subsequent rounds of testing could be representative of this particular variant. As part of the outbreak management team's daily meetings and ongoing surveillance, we're considering that on this home area, there may be 2 separate episodes involved in this outbreak. Though it's difficult to determine, another case was identified shortly after the first case as part of their post-absent surveillance testing, and there appears not to be a direct connection to the initial resident case in terms of their interactions. This is an ongoing investigation, though, with our public health partners, and our public health partners have been on site twice, have reviewed our IPAC practices, and do not see any indications of breaches in IPAC. So, even though we're a number of years into this pandemic, each outbreak is unique, and each outbreak comes with its own challenges and processes that we need to follow and work through. All symptomatic residents remain in isolation and are receiving in-room care and meal service. The team is using a de-escalation approach outlined by Public Health Ontario to help us support increased activity, so being able to be out of isolation and in small groups on the home area, but also balancing the outbreak risk of resident safety and well-being. So again, as we're at this stage of the pandemic where we're working hard to contain spread and also still reduce the number of days that someone needs to be in isolation, make sure that it's not beyond what is necessary. To declare a COVID outbreak over in a long-term care home, 10 days must lapse between the last identified positive symptomatic case. So as long as we continue finding positive cases, the 10 days starts over. So just to remind everyone, that's how that works. And again, the home area will continue to be in outbreak for those 10 days. While inside the home area, we're looking at how do we have a balance between residents that are isolated to their rooms and residents that are able to do a little bit outside of their room. Regarding surveillance, I guess the last thing, I didn't make a note of this, but I do want to just note that managing outbreaks continues to be challenging and a huge amount of effort for the residents, for the designated care partners, and for the team members. And I just want to acknowledge the amount of work and commitment all around that people are putting into managing this outbreak in such a positive way. So thank you to everyone for that. Surveillance testing and PPE, we're expecting an update from the Chief Medical Officer of Health on June 11th. We heard about this about a month ago, projecting that there would be an update about the provincially mandated masking rules in long-term care and healthcare. I want to be transparent and let our residents, team members, and family members know that our plan is to continue with our masking requirement beyond June 11th throughout the summer and into the fall. We continue with active screening for all people entering the long-term care home, and our 3 long-term care homes will continue with daily rapid antigen testing for all staff, students, support workers, volunteers, designated care partners, general visitors. Individuals who've had, and then there's the same, this hasn't changed. So if you've had a confirmed COVID infection, you'll be required to resume rapid antigen testing 90 days past your COVID infection. I want to let people know that this screening is really effective. So while rapid antigen testing isn't perfect, it does continue to screen and identify positive individuals who are positive with COVID-19, allowing us then to prevent them from coming into the home. And we are seeing that screening happening where we're getting positive cases 1 to 3 times a week across all of the homes. So it continues to be a really effective strategy, and we have no plans to discontinue it as long as we have supplies and resources to be able to do the rapid antigen testing. And thank you to everyone who has worked through the process to do self-swabbing. It's really helped us manage this. Just wanted to also remind that universal masking continues with surgical masks, with the exception of home areas that are in outbreak where N95 and eye protection continue to be used. If you're visiting and you would prefer an N95 mask, those continue to be available for you. Eye protection also continues to be available, so for anyone. Regarding visiting, we have updated our visiting policies to be as safe and equitable as possible. So just a reminder, these items haven't changed. Indoor visitors must have 2 COVID vaccines, with the exception of children under 5. And we do have child-size N95 masks available for any children under 5 who wish to wear them. All residents may go on an overnight absence, and testing of residents returning will continue until further notice. This continues. Just a reminder, to arrange a social outing, please call ahead to the registered nurse or the resident family services manager. As we've talked about previously, we continue to use a risk assessment tool to sort out how we might support the outing in the best and safest way that we can. So the change that I wanted to highlight is currently in the policy, it says unvaccinated general visitors will be required to be actively screened, undergo surveillance testing, wear a best fitting N95 mask, and follow distancing and hand hygiene protocols. That is the same. Currently, those visits must be pre-scheduled and at an indoor visit, a designated visiting station. We have added an asterisk to the policy that says consideration for in-room visiting will be made upon request and will be determined utilizing a risk assessment tool. And we will be able to share with you the risk assessment tool. And so if you are an unvaccinated visitor and you wish to visit at the bedside, please make your request formally through the registered nurse or the RFSMs. Resident Family Service Manager, so Kim, Terry, or Elena, and they will support you in working through the process to do the risk assessment and be able to support you, hopefully with the goal of supporting you to be able to safely visit at the bedside. So I wanted to highlight that. Now I would like to share my screen, and let's see if I can do this, and just do a quick overview. I say that, I'll do my best for it to be a quick overview. Okay. Okay. So Olivia, can you just confirm that you are seeing the slide and not the notes and the next slide view?
Yes, I can simply see your first slide.
Perfect. Thank you. Okay. So this is an overview of the Fixing Long-Term Care Act 2021 and Regulations 246/22. It's a new framework that came into force on April 11th. I will do my best to no longer call it the Fixing Long-Term Care Act. It's not my favorite language. I really think that this is an opportunity for us to transform long-term care. There is a lot of excellent work that's happening across the province already in long-term care. There's definitely room for improvement and opportunity to make positive change. So from now on, I'm going to call it the new act, or the new act and the regs, and we'll just leave the fixing off for now. So this new act came into effect on April 11th, 2022. It provides a framework to ensure that every resident experiences the best possible quality of life, supported by safe and high quality care. It's prioritized actions under three broad areas: staffing and care, accountability, enforcement, and transparency, building modern, safe, and comfortable homes for seniors. The new legislation includes enhancing the language in the Resident Bill of Rights, additional language in whistleblower protection, which gives further protection to residents and families from worrying that raising a concern will affect the care or service of their person, their loved one. It streamlines long-term care development and redevelopment process, providing more flexibility in managing licenses that are expiring. It provides a greater emphasis on resident quality care, quality of life, and continuous quality improvement. And I have a slide a little bit later on about that. The implementation of new enforcement and compliance tools, and a commitment to provide a system target average of 4 hours of direct resident care per resident day by March of 2025. And do I have anything else to say that? I can tell you that currently, our current number of direct care hours is at Grey Gables 3.24 hours of direct resident care. At Lee Manor, it's 3.258, and at Rockwood Terrace, it's 3.304. And so we're well on our way in meeting the goal. In fact, we're ahead of things a little of the 4 hours of direct care by March of 2025. The regulations give further detail around the changes and the action items that operators are responsible to implement. And the enhancements, and these include enhancements around ensuring accountability. So setting criteria and amounts for issuing monetary penalties. As I mentioned before, expanding the whistleblower protection, enhancing the screening measures for all staff, volunteers, and members of a board or committee of management. Improving the resident safety, well-being, and quality of life, improving resident experience, emergency planning, the defining of caregiver, which is really, really excellent and good to see in legislation and regulations, and clarifying around staffing requirements. And that's really around clarifying the roles and responsibilities of medical directors and physicians that are providing clinical support. So just giving a little bit of a summary on a few of the areas. So around complaints, the Act requires that homes provide information about contacting the ministry and the patient ombudsman. Under the new legislation, licensees must immediately forward complaints to the director. We're already doing that. And we encourage, and that's the director of long-term care at the provincial level. And we encourage you to voice any concerns regarding the care of a resident or operation of the home in the following way. And so if you have a concern or a complaint that you would like to bring forward, contact the registered staff in charge or contact any member of the leadership team. And I'll flip to the next slide, which gives you a couple of other options as well. I just wanted to add that we have already completed the required changes under the complaints portion of the Act. We've updated the policy, the posters, and the website to include the required information, and our language clarifies the need for immediate reporting of any complaint that alleges harm or risk of harm. And as I mentioned, we were already reporting and following up on complaints of that nature. So just finally on complaints, there are 3 additional methods to report a complaint, and this information is posted on the Grey County Long-Term Care webpage at each of the homes, along with our complaints management policy. And so that information should be readily accessible to anyone. Around quality, this is the summary of changes around quality. So highlighting the need to establish an interdisciplinary continuous quality improvement committee and have a lead. Prepare an interim report for the 22-23 fiscal year on our quality improvement initiatives within each of the homes. and provide a copy of that report to the Residence Council and the Family Council, and to also publish it on our website. To prepare a report on our quality initiatives each fiscal year, and do that every year, provide that to the councils, maintain a record setting out the names of the people who participated in the evaluations of the program. And the Act requires that a licensee have at least once every year a survey taken. And so our 3 homes have well-established quality improvement frameworks and programs. The new language requires the formal report, which we're working on and are prepared to do. And it also requires a resident and family member as a member of the quality team. And so we're working through how to best get expressions of interest from family members and residents who would want to participate in that. So if that sounds like you, send us a note, and we would be pleased to hear from you. Around infection prevention and control, it's no surprise that a significant portion of the legislation and the Act is dedicated to infection prevention and control, in that much of this came as a result of the challenges and tragedies that happened in long-term care throughout the pandemic. So the regulation sets out requirements for IPAC leads, for there to be an IPAC lead, a minimum number of hours dedicated at each of the long-term care homes to oversee, implement, and maintain our IPAC program. It also includes specific minimum IPAC education, experience, training, and certification requirements for the leads. The Act and regulation also requires licensees to comply with a new IPAC standard, which is an evidence-based I might need Dana to help me, an ethical framework, using an IPAC ethical framework in determining decision making. And so we are actively working on building this program to meet the requirements. And I bet it was on this slide, that word that I was struggling with. No, it isn't. So this is just a bullet note list of what our IPAC program must include as we implement it. Palliative care and a palliative care approach. So to care is required as part of the legislation and the regulations. A palliative care approach aligns very well with our resident-centered Color It Your Way promise. And it's a broader approach than just end-of-life care, which is very important. And a palliative care approach starts at the time a person moves in, and it's really about options and choices and what is the resident wants. That's really what it's about. And so this is a summary that outlines the requirements of that. We know that there is some need and opportunity to do some shared learning and education for not just our team members and our leaders, but also our residents, families, designated care partners in our community, and our partners that we work with across the health sector. So this is, I believe, a really important language in the Act to help us move closer to resident-centered or resident-led care. Screening measures. This is really about vulnerable sector checks and police checks, and how we manage and vet the hiring of staff, volunteers, and also the boards of directors. So in the municipality, our board of directors or board of management is our committee, our long-term care committee of management, and they are representatives who are members of council, members of Grey County Council. And so that this information applies to that group. Menu planning, so a summary of changes around menu planning is really focused on flexibility and choice for residents. And so the specific items are bulleted here. Each menu cycle needs to be evaluated, not just by our dietitians and nutrition managers, but also our residents, and they already do this. Menus are to provide a variety of food. They did remove Canada's Food Guide as a requirement for menu planning to align with expert advice that this is no longer a helpful tool in menu planning. So our teams are already working on this, and it's great to be able to provide additional flexibility around meal choices. The visitor policy and caregiver definition. So Grey County long-term care and our families were really leaders in the area of visiting and the formal recognition of caregivers. And I've said this before, but you were pioneers in moving this forward in a really formal, acknowledged way that is recognized, and it's really nice to see it reflected in the Act and the regulations. And so we have this already sorted out. It's already built into our policies. So we must have a visitor policy. We must define essential caregivers and define a caregiver in our policy as a family member or a friend. And importantly, that the resident is responsible for making the designation of who their caregiver is. Emergency planning, again, the pandemic highlighted gaps in the previous legislation around emergency planning. The new language looks to close those gaps. We are well on our way to meeting this language. I'm on a small working group with the Ministry of Long-Term Care and other operators that have worked to create a resource guide to assist operators in meeting the July target. And so this really highlights the partnerships that we have across the sector and within our community to support emergency planning. And so transition periods, this all came into force on April 11th. Many of the regulations were required to be implemented on April 11th. However, to allow operators and licensees time to prepare, there have been some transitional periods set. So most were required to be in place April 11th. Some we have 3 months to implement. The emergency planning is one of them. That takes us to July. And then the odd one, like the certification requirements for the IPAC leads, is 3 years. And so our goal is to meet all of the timelines. There are a couple that are a little worrisome that I'm concerned we may or may not meet the timeline, but we're working at it. Partly it's health human resources. If there aren't people out there looking for work and available to hire in these specialized roles, it makes it really, really difficult. Having said that, we're totally committed to supporting team members that are already working in our teams that might be interested in some of these specialized roles. And finally, next steps. So we're updating our policies and procedures, we're providing education and communicating the new Act and regulations. Our medical directors have been updated on the regulations and how it impacts their role. We're actively working on our quality improvement plan, which will then support the report that is required. And for all of 2022, we've been working to get back to the fundamentals. So out of COVID response and COVID pandemic reaction mode and back to day-to-day long-term care operations has been our goal. And just finally, before I close out, and maybe I can stop sharing, but maybe there we go. The one thing that we talked about with our committee of management, and then we'll get to questions because that was 30 minutes of an update. The the risk that comes with a new act and new regulations is that, and deadlines, is that we become really concerned and worried about meeting the deadlines and checking the boxes. And so we put our heads down and we do that. And then we miss the opportunities that we have to be really looking at the day-to-day care and the day-to-day experience of our residents, our team members, our family members. And so the message is, I am accountable to our vision of color it your way care and experience. And if we are continuing to work towards that promise, we will be meeting the requirements of the legislation and the regulations. And so there's some team members that are behind the scenes working on the policies and the check boxes. And so at the home, the teams in the home shouldn't have to feel the burden of this responsibility. Their focus needs to be the day-to-day experience of the residents, their colleagues, and family members. So I'll close out there. That was a lot of information. Thank you for your patience. Let's see if there are any questions about anything COVID pandemic related, and then I'll do my best if there's any questions regarding the Act.
Thank you so much, Jen. I will check to see if there's any Q&A questions. So just a reminder for anybody who tuned in later, we will be answering questions in the question and answer, the Q&A feature down below. It can be found at the bottom if you're using a laptop or desktop, and near the top of the screen if you are watching this on your cell phone. At the moment, I don't see any questions. I will just see if I can refresh, or potentially people are typing it out. So
yeah, okay. Well, we'll give people a minute or two. And it's okay if there's no questions. That's okay. And I do want to share, and people, if you think of a question after, if we kind of close out the meeting earlier and you think of something, please send in an email and we'll be happy to answer it. And I'll also just highlight that for anyone interested, there will be a communication going out to the Rockwood Terrace email list that there's going to be an update session in person on June 2nd in the auditorium in the afternoon, and there's posters in the home. And then there's a Zoom session as well at 7 o'clock. And we'll be hearing an update from our design architects as to where we're at in the phase, in the stage of redevelopment, and then be able to answer some questions. So that is next Thursday at 7 p.m.
perfect. Well, we do have two questions now, and I'll just read them verbatim. We have one that says, how much flexibility will you have about meal times, for example, breakfast times?
That is a good question, and I'm just looking at my slides to see if I had anything in my notes. And I don't know, Dana, do you?
Yeah, we've been talking about this sort of more in the application, and I think generally speaking, most of the care communities know the resident, who's not a morning person and would rather, so they've been working around some of these arrangements anyway, but it definitely allows, or somebody who's an early riser and would like breakfast at 6 a.m. So it definitely allows for that flexibility in terms of a timing, like is it 2 hours? I think I don't recall something specific, but I see, Jen, you might be looking at the phone a friend. That's one of our phone a friends there commenting, but definitely we've been talking about this, how we can apply. And I think many of the residents are, we're doing our best as we speak already.
And I think also, Janet, I recall, and I'll look this up and share some information back. And we're going to be talking about this. There'll be a few opportunities to talk about this, but one of the pieces that I remember off the top of my head is removing the start time, of dinner time, like of supper, and being able to allow a little bit of flexibility, and also opening it up to more than two choices if meals, if and supporting operators at looking at ways to explore that. So the nutrition management team has been exploring what's possible, and so there'll be more information.
Okay. So our next question is, after a day outing, when is the resident tested and what kind of test do they get?
Well, I'll jump in here. So, and it really depends on the situation for the resident. So, for example, if someone is going out very frequently, multiple appointments during the week, we test twice a week, and that's with a PCR. Now, in some circumstances, if the weather was poor, we might have done a rapid antigen test. I know in some homes we were doing rapid antigen as well as a PCR. And at our Rockwood Care community, we're fortunate, one of the first long-term care homes in Grey and Bruce counties to have an ID now molecular. So we get results within 15 minutes using an ID molecular. So to answer your question, after a day outing, it would be 5 days after that outing. If it was just one outing, if it's multiple times, it would be twice a week. I hope I was clear, but it depends on the situation, and we're really lucky that that hasn't changed in a couple of months. So we're getting in the groove of it, and we have a really nice template that keeps our team on task to complete that. So multiple times, twice a week. If it's one outing, we test on day 5. And that is with a PCR.
Thank you very much. Next question says, if I sit with my mother during one of her meals, am I allowed to go to the kitchen window to get her meal? Her table is quite often served last, and she needs more time to eat.
That's a good question, and I think that's one to discuss at the home. And so I'd recommend that you connect with the registered staff or the director of care, and or the nutrition manager. There's a few options, and talk it through, because I'm sure there's a way we can support that.
All right. Just switching briefly over, as I saw that somebody had posted in the chat. Normally we just answer the questions in the Q&A. However, I'm just going to the chat for one moment. So let's see. So Jen, I just want to make sure this is correct. I can read that out
that's
loud.
okay.
Okay.
You can go ahead. Yeah.
Okay, so regarding waiting times for long-term care in Grey Bruce, can you provide me an update?
I can, and I'm glad there was another question in between. So I was just searching, and I can share that. So what I searched on Google or any search engine is long-term care waitlist Southwest Ontario, and it's a PDF report, and I was able to click on Grey Bruce, and Olivia, we can include the link to this in the follow-up MailChimp that goes out just as follow-up.
Mm-hmm.
And so then there's a chart, which I can't read without my glasses, and it lists the 19 long-term care homes, and then it lists the wait list. So does it give me an average here? Let's see. And it divides it into Grey and Bruce. And so it does give me a summary. There are 19 long-term care homes in Grey Bruce. There are 1,325 long-term care spaces. There's a total of 475 people waiting on a wait list to get into one of those 19 homes. And it's an average of 157-day wait to get into a long-term care home. And that's been over the past 12 months. So that is the update, and we'll include that link so that you can be able to access that anytime.
Okay, yes, we
And
will
I just
include
got a
it.
note
Yeah.
from Sherry that said we also will add the link, if it's not already there, to our Grey County long-term care webpage so that it might be easier just to access it there. Thanks, Sherry. And thanks, Jeff, for the question.
All right. That is very good to know, and we'll have that available soon. So for the next question, again, reading verbatim, is it your opinion that these cases of COVID, which led to this latest outbreak, was contributed to outside visits? Any consideration to modifying the screening of those who had these outside visits, i.e. isolating until negative results on testing?
Yeah, if I can jump in there for sure. There's a lot that goes into an outbreak investigation. And, I think what we take a look at, and as Jen alluded to at the beginning of this outbreak, when we identified it was Omicron, it's highly transmissible. So, and if you've had a friend out in the community who had it and a family member, they wonder how they got it. It's very transmissible. So I definitely think, and that's what we talked about that precautionary principle, that ethical framework that Jen alluded to with IPAC, where we have to balance respect for the person's quality of life as well as that balance with the risk. And so the ability and mental, we want to look at, yes, the IPAC practices, but the emotional, the social well-being of the resident, and the spirits lift when you go out there. So what we want is that precautionary principle. So folks are going on an outdoor outing, and whether it be, the weather's nice or headed out with, it's making sure that we screen, that we're vaccination status, that hand hygiene, wearing a mask is something that we're still highly recommending, social distancing, washing hands, and just being cautious. It's definitely a balance. So while we don't want to say that this last outbreak was directly related, I mean, that is the practice of surveillance and testing to do early identification, to manage it. And ultimately, we would have some significant folks waiting in isolation, and that's not what we're doing. And I think we're trying to do that definite balance. And even when the outbreak is happening, again, as Jen alluded to with what we're doing with Lee Manor, is that precautionary principle, while also balancing, and that ethical framework is certainly helping us walk through that. And I think we're also in a place where not only with vaccine knowledge of IPAC, but also the antivirals about, Paxlovid and remdesivir and other COVID treatments that can antivirals and stop. So it's definitely a balance.
Thank you very much for that, Dana. All right. This seems to be the last question we have on our list. However, if more flood in, that's okay. So when your loved one needs to go to a necessary appointment, so for example, a dentist, why can't the home staff help with loading the resident into the car? Or when the resident returns, exiting out of the car? It seems that they're describing that the cost of a shuttle is quite expensive.
Mm-hmm.
Yeah, thanks for that question. And I know this has been coming up as a balance again for decades. So it really comes down to resident safety and team member safety, and that's really what it's about. So if we have to balance the risk of resident injury and staff member injury, assisting into and out of a car, and a vehicle can be one of the more challenging transfers to be able to support, and so that's why that policy is in place. If we have zero lift policies within our homes, and that's expected and common across the province. And so we support residents to be as independent as possible while balancing the requirement for lifting. Lifting someone is one of the in the old days when that was what happened before we had equipment and tools to support lifting, like sit to stand lift or a mechanical lift. Those devices really helped to minimize and mitigate the risk to residents of having injury and the risk of staff having injury. And so that's what that's about. I do suggest that if there's someone who is kind of on their, that some days they would transfer quite easily into a vehicle and other days maybe not, and there's some opportunity there, I would recommend talking to the physio support, because maybe there's some training and exercises and techniques that you and the resident could practice together as a goal to get to that stage. And that might not apply to everyone, but that might be something that is an option for some people.
Thank you very much, Jen. All right, on to our next question. As a DCP, I have to sit and wait 15 minutes for the rapid test results. I notice that the staff don't. Am I wrong? Maybe they wait somewhere else.
Right, so that's a good question. And so yes, they do wait somewhere else. They are not able to do any direct resident care until they have got the all clear from their 15 minutes from their test result. So there are some things that that staff can do that is kind of behind the scenes, not interacting with other staff or residents. And so they're able to go and do some of those items, but are not able to do any direct care until the 15 minutes have passed.
Okay. Next question is, so the 3.258 hours of care daily each resident, what are examples of care besides baths, snack cart, and meds distribution when your loved one wishes to be independent?
Okay, so that's a good question. It's calculated using the staffing hours that are in place that are PSW, RPN, and RN. So it absolutely covers the support with meals, support with bathing, the activities of daily living. So getting up and dressed and washed and teeth brushed, whether it's doing or supporting. It's those things. It also, I had another one in the back of my mind. If someone is maybe has so medications, like not just pills, etc., but also ointments, etc. It's also wound care, that kind of support. And did I don't know. Dana, do you think I caught some of that, most of them?
There is all of those behind the scenes, as well as supporting care conferencing, connecting and providing, the care, the communication. So it's that broad umbrella. And again, it's an average. So you that 3.258 may not just be for your person. It's considered a collective average. And so there may be days when more independent, days where needing a bit more care, depending upon how your person is feeling that day, or maybe they're recovering from something. So it balances out of an average, not only of an individual, but rather of the care community and broader, province, and for that matter, as we're all trying to maintain that average.
Yeah, and I will just say that it does not include any of the kind of officer leadership nursing positions. So it does not include the director of care. It does not include activation. It does not, or recreation. It doesn't include maintenance, housekeeping, the coordinator. It doesn't include any of those positions. It's really meant to capture the direct care, the nursing, clinical support that's interacting with the resident.
Thank you very much. Next question. Why is the wait area for the 15-minute test wait period out the lobby, out of the lobby with residents before mowing the yard, positive or not, during that time in Rockwood Terrace?
Okay, so I think there's a second follow-up. So
Right, and then
out in the
why,
lobby
yeah,
with residents.
I'm just going to repeat it just for the
Sure,
people
yeah.
listening. So it'll say it adds on to why is the wait area for COVID testing out in the lobby with residents at Rockwood, so Rockwood Terrace long-term care home.
The last time I was at Rockwood, I waited in the testing area. So I don't know if perhaps there's different times where volumes exceed the space of the testing area. And so it's the space is at a premium at Rockwood Terrace, and so they will have done their best to set up waiting and areas so that people are distanced and be able to support that. And I see that Karen is typing something to me. So, and they've also have set up self-swabbing in the conference room. So people can go and do their self-swab and kind of hang out in that space while they wait for their timer to beep, and then they'll be able to head on to their visit.
Yeah, and if I may add too, Jen, that it's because sometimes there are busier times and where there may be a bit more, and we want to continue to maintain that physical distancing. You know, while you're waiting, you're wearing a mask. These are generally well ventilated areas, and I believe Brandon's out of Rockwood has put a few HEPA filters around those areas as well, which supports the air exchange. But definitely we're trying to, until such time as you get your results, not to have any direct resident interactions, because many of our residents aren't wearing the mask, whereas we are when we head in.
Thank you very much.
Oh,
There is one follow-up, and again, I'm just going to read it. Just the same individual is wondering if a bird could be moved out of that area. I'm not sure. Is that indoors?
I don't know. So request duly noted, and I'll pass that on to the Rockwood team for consideration. I don't know where the bird lives or where else it might live, but maybe temporarily it could live somewhere else. So, but I don't even know, I don't recall the structure that the bird lives in. So we will pass that on for discussion.
Thank you very much, Jen. All right. This seems to be a follow-up question about the wait time for Grey Bruce long-term care, asking for an update. This was previously answered, and then I'll answer this question or read this question out. So the same individual asks, you mentioned that currently there are 475 people on our waiting list for long-term care in Grey Bruce. Of this total, how many are new to our area versus current residents? This seems to be a stats question.
Yeah, it's a good question. And I was just looking again at the link, and it doesn't specify that. So I can reach out to our partners at Home and Community Support. I always say that wrong, but previously known as CCAC, and see if they capture that data. And I don't know if they are actively capturing that data, but it would be interesting to see.
Thank you very much. At this time, we have no more questions in the Q&A. If someone is typing in, we could wait a moment while Jen and Dana wrap up.
Sure, we can. I think we've had great discussion, and thanks so much again for everyone being engaged, and thanks Olivia for facilitating, and Dana for supporting the Q&A. In closing, I want to thank everyone again for their commitment and support to the homes, our residents, and our team members. I do want to highlight that there continues to be lots of meetings and within long-term care and then within our partners, and we are all hearing the same trend of being fatigued at this stage of the pandemic. And I think that's accurate for team members and leaders, as well as it is for residents and family members and everyone in the community. Everyone is fatigued at this stage of the pandemic. And the world news has been very difficult to hear and watch over the last few days, and at times can feel like too much or a lot. A friend sent me this positive message that she got in her email today, and so I thought I would share it with everyone. Be kind, say thank you, hold the door open, compliment as many people as you can, point out the good and be good, treat others the way that you want to be treated, love, serve, and care. The world needs more of that today, and I would argue today and tomorrow. So with that, thank you. Nice to see you all, and enjoy the rest of your evening.
Thank you very much, everyone. And that concludes our long-term care family call. You will be receiving an email from our long-term care MailChimp. Everyone will receive that, and you will be able to rewatch this video after it has been posted on our YouTube channel. Thank you very much, everyone. Good night.